All right, let's discuss a hand case that we are working with. I had this whole idea. I didn't do it yesterday, so now I'm like, ugh. Oh, goodness. All right, we have a metacarpal fracture 2 and 3, right?
Yes. Yes.
It was pinned. Date of injury.
Late. Oh my goodness.
Give me a roundabout.
Okay. October 28th.
October 2023.
Of 23.
Right. Okay. So just need a roundabout date because it's so far.
Date of injury, not date of surgery, not date
Well,
of.
the date of injury and date of surgery are the same for the pinning, right? And then the pin was removed.
Okay.
Right? Because a pin doesn't stay. So pin removal is
Like 12 the second.
12/23.
Oh yes.
So it's 6 weeks pinned, right? So we are now currently 9/24. So we're almost a year out from the initial injury and surgery. We've been trying to avoid another surgery, right? We haven't been able to avoid it, right? So now we have to say, well, what are the problems, right? Or what are the symptoms? AKA problems. So that we can make our recommendations. Right? So we, when you study to become a certified hand therapist, part of studying, let's face it, part of studying is because it's recognized in the hand therapy world, you don't have to explain yourself away because you have these letters. So you could be a hand therapist and be really great at your job, know exactly what you're doing.
Those are your initials.
It's
meant to be.
It's meant to be a hand therapist. Right? Huang Tron Secrets. It's pretty much the same. I just called it hand therapy secrets so people wouldn't think. No, I just didn't think about that.
Okay.
But you can be a hand therapist, have a shit ton of experience, make the recommendations because you know X, Y, and Z, and you know how whatever, and that's powerful, right? You can be a CHT and not know anything. You just passed a test and got some letters behind your name, and you don't know shit from shit of how to recommend. Let's be honest, that happens, right? You can have both, and you can be more powerful. I want to put it like that. If you have the clinical application, that knowledge, that experience, and all that good stuff, and you have your CHT, you're exceptionally powerful, right? That should, give you a certain amount of confidence that, this is what people are looking for. People are looking for this. Your therapist is looking for this. Your surgeons who want to work with a certified hand therapist, this is what they're looking for. They're not looking for someone who's a CHT that has no recommendations, right? They're looking for, they want to have that collaborative energy that says, oh, this is what I'm seeing. What do you think? So when that happens, you want to be powerful, right? I'm just using that word, but you want to have really good sound recommendations, not because you know everything, but to be collaborative, right? So the question kind of comes down to, how do you do that? Is that the question? How do you go about doing it?
Yeah.
Right? How do you see the symptoms, be able to apply it so you can make the appropriate recommendations. Is that what we want?
Mm-hmm.
So that not only can we, help the patient feel confident about the next step, because it's a big deal. It's a big surgery that we're talking about. We're not just talking about, like, her hand is essentially non-functional. She can open it, but she can't make a fist, so she feels really stuck, right? So outside of how long it has been, once you move into that chronic stage, we have all sorts of problems. So I always say, go back to the fast track framework and say, okay, well, what's involved? The joint, the muscles, the ligament, like what else is going on, so we can make the appropriate recommendations, right? So what are her symptoms now? She has a certain amount of stiffness, right? So from a stiffness standpoint, you have to then say, is this a joint problem, right? Is this the quote unquote stiffness? Is it a muscle tendon problem, right? If you determine these are the issues, then you have to go and say, well, which joints? Which ones? And then from a muscle tendon issue, you also have to say, which ones? Right? So, you go back here and you say, well, the pins are removed, or her scars are back here, right? They're dorsal. So we have a stiffness, or we have a limited motion. Limited motion. Biggest problem, limited motion. Where? Where and which ones, right? Her second problem is pain. Due to what?
The lack of motion. Limited motion.
Well, her pain is due to lack of motion, stiffness, which then goes to here, right? But there's another component of this, which is not just joint, muscles, and tendons. There's a nerve component to it that causes pain, right? So, with that chronic nature, the doctor was like, well, she kept saying this, and this, and so I decided to have a nerve conduction test, right? He had an EMG test, which shows it's positive for median and ulnar disruptions. And I said, well, that might be true, but if we're looking at which surgeries to do, I don't think that this nerve, so if the median and the ulnar nerves are impacted, then the surgery that's required is a cubital tunnel release and a carpal tunnel release, right? I understand, doctor, but she shows no symptoms of numbness or anything like that. And yes, sure, there's a median of course, because the whole hand, intrinsically, she's tight. Well, we're gonna get to that, right? But if we're talking about surgeries, we're talking about multiple things in one day. Is she able to tolerate it? Doctor, I don't think so. I think if we focus on the other things, we can reduce this need. And if we need to do this, we can potentially do this later. Him and I, we went back and forth on it, and we were like, yeah, you're right. Let's address that later. Let's address that later, because that is not the most important thing, right? If you released all of those, will it fix these problems? It won't. We have a fundamental mechanical issue that does not allow us to make any progress. If I promise to move some shoulders and do some nerve glides after this, that can get better and we can address it later. That's a minor problem. But if we do that now, it won't fix the the major problem. So in a way, you're prioritizing. It's not that it's not a problem. It still needs to be documented, like, hey, this patient has this problem. We'll address it in therapy, but like from a priority standpoint, it goes to the bottom, right? Somebody who's really into nerves might be like, that's a number one problem, right? But her pain is not just due to nerve, it's due to that lack of motion. So if you have someone who has that lack of motion, they're constantly like this, what muscle do you think, is tight, right? So then you go and you break it down. So you can go joint by joint, which we did. And actually, the doctor was like, thank you so much for sharing that. Like, we went specific. We went joint by joint. MP, right? 1, 2, 3, 4, 5. MP is stuck, right? The MP of the index finger is stuck. It's right next to the long finger. They're stuck. There's a certain, and you have to, the experience is just to feel the, how do you call it? It's to feel the joint play, right? These move, they have a certain bounciness to them, right? But these two are much firmer in joint stiffness or joint give, right? So we are deciding if this is the problem here, right? Then what we want to consider is a capsulectomy, and we want to consider the tenolysis, right? These are the two when you're stuck, surgery number 1, surgery number 2. But now we know the patient's history. She's a little bit more guarded. She's a little bit more like everything hurts. She's a little bit more fearful of moving. She's got all the psychological stuff, right? So we have to be considerate of that. We also know like her body heals and presents a certain way. So poof goes magic dragon, and she swells up in like 2 seconds. So we don't want to do the surgery and be so aggressive that poof, she gets really swollen again, right? So what we're trying to do is manage that. It's very easy to be like, capsulectomy everything, tenolysis everything, right? So we had already determined, how do we determine tenolysis? That's this test right here, right? And that's this test right here. So from a tenolysis standpoint, the test that you need to do is to rule out, what's a test? To rule out joint contractures and to say definitively is a tendon, right? So how do we do that? So we, what do we do? Vouvier's and Venel's, right? So it's like, oh, from an intrinsic standpoint to an extrinsic. So if we move this knuckle, each individual, right? Each individual, they were fine individually, right? If we try to move them together, it did not give, right? So it wasn't the MP, it wasn't the PIP, it wasn't just the MP, it was combined together, it would not close the hand. So we also have old scars there. So it's already giving us a clue that we have extensor, we have extrinsic extensor tendon scarring, right? So because we were able to determine this, that needs a tenolysis. And the tenolysis is a relatively easy procedure. So it's gonna go, and the question is, do we do only 2 or we do all 4, right? To do all 4 is very easy. And I think that she's gonna need all 4, right? Because when you hold her MPs down, these don't wanna curl down either. So if you're gonna go, like, just go and do all of them, and then you can see if it's looser, right? So then the question is, how many capsulectomies? So we know that joint, 2 and 3 are really tight because we try to push it, we try to extend it, and it's really, really firm. Like, it's giving less than the other 2 ones. So then the question became, do we do capsulectomies on all of them, or not? And I was like, well, considering, her fractures are on these 2. These 2 are the hardest ones. And I was like, considering how she swells up and her scarring and stuff like that, if we didn't have anything done to these before, and we can release it from a tenolysis standpoint, if they loosen up, I wouldn't want to do capsulectomies on these knuckles, because we're gonna put her at risk even further. Now, if they do a tenolysis, because the tenolysis, you're already in there. That's why it's like, since you're already making the incisions, right? And you just clean up the tendons. After you move the tendons, you should be able to see if the capsule moves too or not. So if these move and give a lot, then we don't need to do capsulectomies.
The tenolysis is always performed first.
Yeah, because it's the easier one.
Okay.
Well, I don't know what the doctor's gonna do, but technically, like, when I was talking to him, I was like, he was like, yeah, the tenolysis is easy. It's the capsulectomy from a surgical standpoint that's a little bit more technical and hard. And I was like, yeah, because you got to go into the joint and you got to release, right? But the tenolysis, he's like, that's really easy. I said, so let's do all the tenolysis, check the fingers and make sure, because if these feel really loose and give, then we don't need to do capsulectomies here. We can just plan for a capsulectomy of 2 and 3. I mean, he might have to put on the paper, like, if this is required, then I can do capsulectomy on 3 and 4 and 5, right? But I was like, technically speaking, like, we might just need to do 2 and 3. Hold up, she has another problem, right? And her other problem is that her pain, lack of motion, and all that stuff has led to trigger fingers, right? It has led to trigger fingers because her intrinsics are so tight, her tendons are, so, like, not on its track. Like, I always describe trigger fingers like having a wedgie, right? Stuck in one direction, and you can't get it unstuck, and it just keeps clicking. And I was like, she's got a trigger here and a trigger here. So when you go and release this, you might as well do trigger finger releases, because yes, it does create more swelling, but she's already gonna have, she already has that, right? But if we don't get rid of the trigger finger, then every time she makes a fist, she's gonna have so much pain, it's going to stop her from making the movement, making the progress. Does that make sense?
Yeah.
So that's the conversation. So my conversation is all based on what I talk about: understanding my anatomy, understanding the nature of the, my anatomy, understanding the nature of the tissue, understanding the problem, applying that problem, right? Knowing how to evaluate, knowing how to test, right? Knowing which muscles are involved, which muscles are not involved, right? Knowing the procedure. I gotta know the procedure, and I gotta know, based on the procedure, well, not just based on the procedure, but because I know all the muscles and I know all the problems and I know the cascading effect, right? So if as the expert, I have to see the problem beyond the initial step. I have to be able to see the problem 2 to 3 or 4 steps ahead of the time, so I can plan and I can plan for it appropriately, right? If I release a tenolysis but I don't do the capsulectomy, I might get stuck again because the joint does not move. And so if the joint does not move, the tendon cannot glide. So now I'm shooting myself in the foot and not doing the other procedure, right? I'm not doing the procedure, not recommending it appropriately. So I'm like, doctor, if we do one but we don't do the other, I might be stuck again. I'd rather not be stuck, right? Doctors get just as frustrated as therapists and just as frustrated as patients. Like, I see this in the OR. I get their fingers down, but then they get stuck again. Well, listen, we're not perfect, right? We all play a role. But if you release the tendons and from the tendon release, you don't feel that joint gave anymore, then we do a capsulectomy. And we do a capsulectomy on all the fingers that are required. Let's please not do it on the fingers that are not required because they weren't injured, but now they got stuck as a result. So is there a way that we could see how much give the tenolysis gives, and then if we don't need to do a capsulectomy, we don't do it, but if we need it, you do it. And he was like, yeah, that sounds like a good game plan. Right? The requirement is your ability to know the information, apply it, and then have the fucking balls to make the recommendation. Right? Like don't shut up because you don't think that you know enough. Like, you know enough, but you can have a conversation in a way that's very collaborative. You know what I mean? You're not, when you're studying to take the exam, I always tell my students, like, you have to act like you're the one telling the doctor what to do, because you have to have that mental mindset to not get fucked over by the exam. That's pretty much it. But in the real world, it's more of a collaborative thing, Like, you have to build the trust so that you can be collaborative, right? This is the collaboration comes from the trust that I have built over a period of time, because I had the balls at some point in the past to say, hey, based on X, Y, and Z, I think that this might be a good idea. What do you think? I'm not telling the man what to do. I'm saying, what do you think? This is what I'm finding in therapy, right? So that we're on the same page, so that, we're, working together in the best benefit of the patient. This is what I'm seeing and this is what I'm finding in therapy. What do you think, right? They know more about the surgeries and all that stuff than me. I don't know that. I'm not doing the surgery. So I'm not, I'm not fearful of stepping on any toes, because they're going to see other things that I just don't see, right? But I might see stuff that they don't see. And I'm like, doctor, if we do the tenolysis and the capsulectomy, but we don't release the trigger fingers, we might have somebody who keeps triggering, and then because they're painful, they won't move. If we're going to release, if you're going to be releasing trigger fingers, let's do both of them. Why only do one, right? I hear it and feel it the most here, but it's next. I don't feel nothing on this one, right? But it's very, this one is she has a lot of pain with this one. I don't feel it every single time, but dude, they're adjacent. They're next to each other. They're like best buds, right? And if I don't release both of them, then I might be screwing myself down the line trying to get her to move her hand, right? Does that make sense, right? So she's stuck, so the extrinsic extensors are scarred down, but her intrinsics are really tight. We know that from clinical testing. Her intrinsics are really, really tight because she's been stuck like this from the pinning, and then she hasn't been able to really open, and she works like this all the time. So then you're in this position and you're constantly getting tighter and tighter and tighter. So we know that those muscles are really tight, but
Can you get her to potty? Just have her play with potty for me some little bits.
Which one?
so we know the intrinsic muscles are tight, right? To do it, intrinsic muscle release is to release it from here, from the PIPs. I've seen it like once. It's not great, right? It's not great. Here's the thing with the intrinsic muscles. The intrinsic muscles, well, some of them, right? They attach to the lateral band of the extensor hood. So if we release the extensor tendons and the extensor tendon as a whole moves better, you think the intrinsics will move better? The answer is yes. The answer is yes, right? Like that gives us a better chance going into the same, kind of like that same area versus going in and causing even more havoc at the PIP. And the PIPs are not stuck. If the PIPs were stuck from a capsule standpoint, we'd be having a different conversation. But the PIPs are not stuck at a capsule standpoint. So let's not mess with the PIPs if we don't have to. And so that's how, even though the intrinsics were tight, even though they're tight, we don't have to do surgical stuff to release it. If we release the triggers and release the extensor tendons, automatically we can get some more motion, right? So we got to work on this, right, which is going to loosen up the intrinsics, right? And then we've got to work on just overall, full joint motion. But we have to have extension in order to get flexion, right? We have to get extension in order to get flexion. We also know from patterns of movement and what we have seen is that the intrinsics can get really tight when the nerves are impaired and the shoulder's not moving well. But if she has this problem, she has been stuck like this the entire year. Every single time she tries to move, what do you think she's doing with her whole arm? Right? And so in order to release the intrinsics, you got to do your favorite stretch.
Sleeper stretch.
That's a sleeper stretch, by the way. You gotta move the shoulder. You gotta do nerve glides. You gotta move the nerve, right? To move the nerve, you gotta move the freaking shoulder, right? So she's got to move those areas to then move the whole hand. But she's been stuck from a mechanical issue right here. We release this, we can work on this, and we can work on the nerve, the shoulder. The shoulder is specific to releasing the intrinsic tightness. I've proven it over and over and over again that the intrinsics are extremely tight when the shoulder is not working well, right? You release the shoulder and the intrinsics will work better. It will also work better once we fix the problem of it being stuck from a scarring issue. So the tenolysis and the capsulectomy and the trigger finger releases allows us almost like a clean slate again. Does the surgery cause edema? Yes. Does the surgery cause scarring? Yes. But now we're not protected. Like, we don't have to hold a certain position. We don't have to, we just need to be aggressive with moving it. And moving it in a particular order will give you better results than not moving it in the particular order. And this is why I teach not working just across the table. They're like this, and then you want to know why their fucking intrinsics are tight, right?